Okay. Okay, good afternoon, everybody. Today, Hematology at Baragwanath Hospital will be presenting the deep dive, and it will be a joint presentation from two of the fellows at Baragwanath Hospital, Dr. Romana Jasset and Garrick Loudon, and it's entitled Adding Some Color to Gray Zone Lymphoma. We don't have too many people yet on, but I think we should start. So we keep to time. Are you ready, Romana, to start? Hello?
Hi, Dr. Philip.
Hi. Are you ready? Can
Yes,
we go ahead?
Just give us a few minutes.
No problem. Okay.
Good afternoon, everyone. Can you hear me?
Yes, we can hear you.
Thank you, Dr. Philip. Thank you for the kind introduction and for the opportunity to present. My name is Romana Jassat, and I'm from Chris Hani Baragwanath Academic Hospital. And together with my colleague Garrick, we will be adding some color to the often murky topic of gray zone lymphoma. I'll just move to the next slide. So this is the outline of our presentation. We'll start off with patient 1, which is a case of newly diagnosed gray zone lymphoma. We'll move on to patient 2, which will be more in the vein of relapsed refractory gray zone lymphoma. We'll touch a little on the definition, including the new WHO definition. We will discuss the clinical presentation of this often confusing disease entity. We will discuss the diagnostics involved in gray zone lymphoma, followed by the management and whether there is a standard of care for the management of gray zone lymphoma. Next, we will also discuss the management of the often complicated relapse refractory cases. We will discuss the pharmacology involved, including the new targeted therapy, and we'll add some spice throughout the presentation with some of the local Baragwanath experience. Unfortunately, for those of you that are fans of Lord of the Rings, this type of gray will unfortunately not be covered and will not be in the scope of this presentation. And also for those of you that have got a cheekier sense of humor, neither will this type of gray be covered. So I'll start off with patient 1, Mr. GPM, who is a case of newly diagnosed gray zone lymphoma. So Mr. GPM is a 42-year-old male patient who had a background ECOG score, a good baseline of 1. He had no significant background medical history. In addition, he was RVD non-reactive. Mr. GM presented with a 3-year history of progressively enlarging peripheral masses, which were lymphadenopathy. In addition, he complained of significant B symptoms. And the delay in his presentation was multifactorial. The patient did vocalize, that at the time it was the COVID pandemic, and he was reluctant to seek medical care at the time. Ironically, though, his current complaint was that of a cough with associated progressive shortness of breath. And the concern now was ironically regarding COVID pneumonia. And this was the reason for his presentation in February of this year. On clinical examination, Mr. GPM had generalized lymphadenopathy, so including bilateral cervical adenopathy involving the anterior and posterior cervical chain. The nodes anteriorly appeared inseparable from the thyroid gland. In addition, he had bulky supraclavicular adenopathy, bilateral axillary, as well as inguinal adenopathy. On its abdominal examination, there was a 5-centimeter hepatomegaly present. And also an examination in terms of his anterior chest wall, there was a mass that was quite bulky, 8 by 10 centimeters in size. On chest examination, there was decreased A entry bibasally, indicative of bilateral pleural effusions, and there was a positive diaspine sign indicative of intrathoracic adenopathy as well. However, there was no features of SPC obstruction at his initial presentation. Some of the baseline investigations that were done included the staging CT, and the staging CT showed extensive nodal disease above the diaphragm, and this anterior mediastinal mass, which encased the SVC and the mediastinal vessels and extended beyond the chest wall, actually into the pectoralis muscle. He had bilateral small pleural effusions, pericardial effusion, and the negative findings was that there was no bony lesions, hepatic or splenic lesions, or any infradiaphragmatic nodal disease. The bone marrow aspirate and trephine showed no infiltrate. So these are some of the pictures of the patient used with his permission. As you will appreciate, the bulky anterior and posterior cervical adenopathy, even extending anteriorly, and the bulky supraclavicular adenopathy as well. This is the anterior mediastinal mass, which I alluded to earlier, which extended from the mediastinum actually into the chest wall. So it was one and the same, disease entity. And this is the patient's baseline chest X-ray. You will appreciate the large mass occupying more than a third of the thoracic diameter and more than 10 centimeters in size. So some of the baseline investigations included a thrombocytosis as well as a lymphopenia. The urea and electrolytes and calcium magnesium phosphate were all normal at presentation, indicative that there was no tumor lysis at presentation. He had increased ALP and GGT, markedly elevated LDH as well as beta-2 microglobulin. His RBD test was negative, hepatitis screen was negative, and the COVID swab was negative as well. So the investigations that they started off with was a fine needle aspiration, and the first fine needle was done in February. Unfortunately, it was paucicellular and therefore non-diagnostic. About a month later, he proceeded to have a second fine needle aspiration, and this one showed a background inflammatory type of infiltrate, and given the inflammatory nature of the infiltrate, this was very suggestive of Hodgkin lymphoma. The patient had his first biopsy, and this was a core biopsy of the anterior chest wall mass. And we can discuss a little bit later if a core biopsy is actually preferable in the case of gray zone lymphoma, or whether an excision biopsy is preferable because of the various type of tissue that you may find in the same tumor. So in terms of the core biopsy that was done, it showed a background inflammatory infiltrate that was in keeping with Hodgkin. But in addition, there was these large pleomorphic cells. The consideration now was that of a hematolymphoid infiltrate, and some of the immunohistochemistry that was done included the positive B cell markers CD20 and CD79A, and then some of the markers for Hodgkin, CD15, 30, and PEX5 were also positive. Out of keeping with Hodgkin was the high Ki67 index of 90%. The interpretation at the time was that this case was difficult to interpret, both due to the staining and the dual nature of the cells, but also because of the type of biopsy, there being a core biopsy, and it may not actually be representative of the actual pathology. Fortunately, though, an excision biopsy was also performed at the time, and it showed in this case two distinct populations of cells. Number one being the Reed-Sternberg-like tumor cells with the background inflammatory infiltrate, together with the dense fibrous bands which were nodular, so that was in keeping with Hodgkin. And on the other hand, this more pleomorphic type of pattern of cells that were arranged in clusters and sheets with marked variation in size and morphology. Again, the Ki67 index was very high at around 90%. The immunohistochemistry that was done on this biopsy showed a positive B cell marker CD20, as well as the markers for Hodgkin 15, 30, and PEX5. The conclusion in this biopsy was a little bit more definitive, and the diagnosis was that of a B cell lymphoma, unclassifiable, with features that were intermediate between both classical Hodgkin lymphoma on the one hand and diffuse large B cell lymphoma on the other hand. So these are some of the images that were taken courtesy of Dr. Pather from the NHLS at Baragwanath Hospital. The first slide you will see, and you will appreciate, it may not be too clear, but you will appreciate the background inflammatory infiltrate. You can appreciate the pleomorphic nature of these cells, these large pleomorphic type of cells as well, and then these multi-nucleate, binucleate type of cells as well. So a mixed type of picture. This is the CD20 stain that was done, and as you will appreciate, it's diffusely positive. The CD15 stain and CD30 stain was also done, and it's weakly positive with Golgi accentuation. So the patient, in terms of his management, and we will move on to this a bit later, was started on a regimen that was CHOP. He had 3 cycles to date with significant improvement in the size of his nodal masses. And after this presentation, perhaps we should consider the addition of rituximab for the remainder of his treatment. I'll now just hand over to Gary to discuss Mr. KM, which is the second case, a patient with relapsed refractory gray zone, before we move on to the discussion. Gary?
Okay. So good afternoon, colleagues. So patient 2 was Mr. KM, who was a 33-year-old male who was HIV negative, had an ECOG performance status of 1 at the initial presentation. He was a social ethanol user and admitted to recreational use of CAT previously. He had a history of lymphadenopathy since 2015, so it was a 2-year duration at the time he saw us in 2017. And this is associated with B symptoms as well as pruritus. His lymphadenopathy was painless, it was waxing and waning. He was initially seen in private in 2017, and he was then referred to Baragwanath Hospital for workup. At that point of his referral, he was referred with an HB of 4.7. On examination, he had generalized lymphadenopathy, which was deemed to be significant. It was again 1 to 3 centimeters in diameter, and this was associated with hepatosplenomegaly as well. His initial lymph node biopsy that he had in August of 2017 showed features of granulomatous inflammation. So at this point, he was put on anti-TB therapy. I'm not sure if this lymph node was a core biopsy or if this was actually an excisional biopsy. He then had a repeat lymph node biopsy in September of the same year, which showed that there were features that were consistent with B-cell lymphoma, again with features that were unclassifiable and intermediate between diffuse large B and Hodgkin lymphoma. At the time of his bone marrow in August 2017 as well, it showed that his bone marrow also presented with an infiltration, which later confirmed that these same features represented on the lymph node were consistent with those that were found in the trephine as well at that time. So again, on stage CT, he would have been in stage 4 already at this point, so stage 4B with the B symptoms, as his bone marrow was infiltrated at this point. But the extensive bilateral cervical nodes, multiple mediastinal nodes as well, with a conglomerate of 2 centimeters, bilateral hilar nodes, multiple lytic bone lesions, multiple abdominal nodes as well. And again, confirming that he did have hepatosplenomegaly with the spleen showing hypodense lesions. So in terms of the bone marrow trephine biopsy, so these are courtesy of Dr. Vaughan and Dr. Hodkinson at Chris Hani Baragwanath Hospital. The initial marrow showed features of marrow necrosis that is indicated on the left by the arrow on the left and the image on the left. Again, on the right, you can appreciate that there's a hypercellular bone marrow trephine in these expanses that are seen. And then maybe a bit more difficult to appreciate here, but there are presence of inflammatory cells and increased background disorderly fibrosis in some areas as well. On 10 times high power field, again, marrow architecture appeared a bit distorted. It's a bit difficult to make out some of the nuclei. But again, there were inflammatory cells and increased background disorderly fibrosis. On 60 times high power field, there were, you can see as indicated by the arrow, again, a bit more distorted, but there were scattered multinucleate tumor cells that was dispersed throughout the bone marrow. On immunohistochemistry, again, in the 100 times high power field, you can see again, there were scanty tumor cells that were membranous positive for CD20. And again, areas of these tumor cells that were binuclear tumor cells that were CD30 positive with paragolgi and cytoplasmic staining. Again, quite difficult to find within the sample, but nonetheless present. Again, further immunohistochemistry on these cells show that there's paragolgi staining, which was CD15 positive in the tumor cells. So again, let's just summarize the long and the winding road in terms of this patient's progression through the healthcare system and at Baragwanath Hospital. So the lymph node biopsy confirms gray zone lymphoma. He was treated with TB treatment for 6 months based on the chronic granulomatous inflammation as well. Up front, he received 9 cycles of ABVDP. After cycle 4A, he had a restaging CT, which showed that there was features of residual disease. But after cycle 7A of ABVDP, he had marked regression of his lymphadenopathy on that CT. So a PET CT that was also performed. Again, this maybe sparks debate as to what may be more useful for determining residual disease and disease activity. But in this case, we had found that there was FDG avid disease on both sides of the diaphragm. This was 1 year later after his diagnosis, with associated increased uptake in bony lesions. So it was then elected that he would receive 6 cycles of R-CHOP, which he completed. So the repeat PET CT scan in February of the following year showed that he still had residual disease, in a single pelvic lymph node and his right pelvic bones. It was discussed with radiation oncology, and they felt that the disease was too extensive for involved field radiation therapy at that point. So subsequent to that, he received 9 cycles of ICE. Again, with access to brentuximab vedotin, there was an issue with getting it in the initial cycles, but certainly with the last 3 cycles of the 9 cycles, he received brentuximab vedotin. Again, he then presented earlier in 2022 with residual lymph nodes that were present. Again, unable to get a biopsy of these lymph nodes due to delay from surgery. However, the bone marrow did show that there were features of infiltration with, again, this B-cell lymphoma, which was unclassifiable, with features intermediate between diffuse large B and Hodgkin lymphoma. At some point, it was decided whether or not this patient would be for palliative, palliative care, but it was decided again that we would consider brentuximab vedotin monotherapy. This patient was young, wanted to give him a chance. Unfortunately, the patient demised, and this was attributed to the progression of disease, and this was early in July 2022. So just to summarize it, we've got a 38-year-old gentleman who's an ECOG1, who was HIV negative with no significant comorbid conditions, who was diagnosed again with relapsed refractory disease, and this was in August, September 2022, and it was stage 4 disease. So, he had a number of PET positive CT scans, 2018, 2019, and multiple courses of chemotherapy. Discussion.
Thank you, Gary. Okay, I'll start off with the discussion. So Grey zone lymphoma is also known as B-cell lymphoma, unclassifiable, with features that are intermediate between diffuse large B-cell on the one hand and classical Hodgkin lymphoma on the other hand. And the reason for this is that there's a lot of morphological and immunophenotypic overlap, and it results in a spectrum of disease presentations, or a hybrid type of disease presentation as well. What do I mean when I talk about this hybrid type of disease presentation? I'm talking about diffuse large B-cell on the one hand, and the prototype, or how these patients generally present, is similar to that of primary mediastinal B-cell lymphoma. But it's important to note that patients with gray zone can have a mediastinal presentation where it's termed MGZL, or they can also have a non-mediastinal presentation where they present with systemic or peripheral adenopathy. And on the other hand, you have classical Hodgkin lymphoma, and in particular, what is noted is that they may present in a similar way to nodular sclerosis, Hodgkin lymphoma. It's important also to note that this disease entity is quite rare. There's a limited amount of literature available on this topic. It was first described in WHO in 2008, with subsequent modifications in the WHO classification thereafter. And it's also important to realize that this disease entity is quite complex, and the complexity exists with regard to the actual diagnosis, with regard to the treatment options, where there's no actual standard of care for the treatment of gray zone lymphoma. And also there's complexity with regard to the prognosis and relapse rate, where it's thought that the outcome of gray zone lymphoma is inferior compared to either diffuse large B-cell alone or Hodgkin lymphoma alone. So this is the new WHO 5th edition definition, and what they are saying, or what should be considered, is that the unclassifiable definition is out, and what is preferred is that those patients that present with a mediastinal presentation, they should be termed mediastinal gray zone lymphoma, and all other patients that present with systemic nodes or with a peripheral type of presentation, they should rather be referred to as diffuse large B-cell lymphoma, not otherwise specified. And the reason for this change in the definition is probably related to the biology of the disease. And I think the slide illustrated it quite nicely. As you will appreciate on this slide, you have the thymic niche or the mediastinal type of presentation and the non-mediastinal type of presentation. So aside from the clinical differences and the age of presentation, etc., the main difference is in terms of the mutational landscape and the gene expression profile, where the mediastinal presentation, generally there's an absence of BCL2 and BCL6 expression, and they present more in keeping with primary mediastinal B cell or in a classical Hodgkin lymphoma type of presentation, as compared to the non-mediastinal presentation where you have BCL2 and BCL6 expression. And in terms of the gene expression profile, it's more in keeping with diffuse large B cell. And therefore, the non-mediastinal presentation is better represented by diffuse large B cell, not otherwise specified. Just to illustrate the basic point here is that this concept of gray zone lymphoma, which is a hybrid type of disease entity, is different from the concept of composite lymphoma. And composite lymphoma is where you have two distinct type of lymphomas which exist in the same location at the same time, also known as synchronous type of lymphoma. That's different from this hybrid gray zone mixed bag type of presentation. And it's different from sequential lymphoma, where you have the development of classical Hodgkin lymphoma after diffuse large B cell, or vice versa. Generally, classical Hodgkin occurs first, and this is known as metachronous lymphoma. So just a clinical point. In terms of the clinical presentation, I think this is a table that just illustrates the difference between the presentation of primary mediastinal B cell, classical Hodgkin lymphoma, and gray zone right at the end. So just to illustrate the point that generally it occurs in the young, but to note that mediastinal gray zone lymphoma, that with the mediastinal presentation presents younger compared to non-mediastinal gray zone lymphoma, where it actually occurs in the elderly and they generally present with advanced disease. Also, another point with regard to gender predilection, primary mediastinal and classical Hodgkin generally occurs predominantly in females, as compared to gray zone, where the predominant presentation is that of males. The site of the disease is variable. Any disease entity can present with these bulky anterior mediastinal masses. In the literature, they particularly mention supraclavicular adenopathy as well, but also to note that any other peripheral nodal groups can be involved. The complications will obviously be as a complication of where the lymphadenopathy is or where the disease exists. So you may have compressive effects, you may have SVC obstruction. It depends really on the site of the disease. And the outcome of primary mediastinal and classical Hodgkin is generally good. You may have secondary complications as a complication of your therapy, but in terms of gray zone, it has a poorer prognosis than either disease entity. It has a more aggressive clinical course, and generally there's more frequent relapses. So this is a study which I recommend everybody to read. It's the largest descriptive analysis that we could find on gray zone lymphoma, and it's by Professor Andrew Evans, and it was published in the American Journal of Hematology in 2015. And this was a retrospective study that was done across 19 centers in America, and their largest cohort of gray zone lymphoma patients consisted of 112 patients. And I'll use this as a comparison for some of the Paraguana statistics that we have available. So we did do a retrospective analysis of all the cases of gray zone lymphoma at Paraguana Hospital from 2014 to current, so to 2022, so a period of 9 years. And we had about 20 cases that we could find, smattering of cases in the early years, nothing before 2014, and the largest number being in 2021, so 20 in total. And I'll compare the baseline characteristics from the large cohort from Professor Evans with ours. So in terms of the male to female predilection, we both noted a male predominance as expected. Theirs were 1.8:1 and ours is 1.5:1. The median age of presentation in our study was older, 47, but this is probably related to the higher percentage of non-mediastinal disease in our study. In terms of the ECOG status, performance status, a large percentage of their patients presented, with a better ECOG status of 0 to 1, but we also have a delay with our presentation of our patients, and therefore they had a later or a more advanced ECOG status. The patients' majority had B symptoms. In terms of bulky disease, 45% had a mass lesion more than 10 centimeters in size, 20% had bone marrow involvement in presentation, and interestingly, only 20% had mediastinal involvement in our study. So the majority had a non-mediastinal presentation. And I think this is also highlighted in the study by Professor Evans et al., where he highlighted the high percentage of non-mediastinal gray zone. So you should not only consider a gray zone lymphoma to be a mediastinal entity, but also as something that may exist in a non-mediastinal presentation. I included the RBD status in our patients, where 60% were actually RBD negative. To just break down the mediastinal gray zone versus the non-mediastinal presentations, 20% were mediastinal and 80% were actually non-mediastinal. In terms of how the mediastinal patients presented, they had a younger median age of around 30, all presented with anterior mediastinal masses in addition to peripheral adenopathy. One presented with area obstruction, one presented with SVC obstruction, but none had bone marrow disease at presentation. And this was compared to the non-mediastinal presentations where it was quite varied. As expected, they had an older median age of 48, all presented with peripheral adenopathy. And then we had a whole spectrum of other presentations. We had 2 patients that presented with paraplegia due to a paraspinal mass, and the diagnosis of gray zone was made on the biopsy of the mass. 1 patient presented with obstructive jaundice, 1 presented with recurrent bowel obstruction, and 4 had bone marrow disease at presentation. So I included this slide just to illustrate the biopsy sites and to illustrate the heterogeneous presentations at Baragwanath Hospital. I also wanted to highlight that an excision biopsy is preferable to a core biopsy due to the variability in a tumor sample, and you may not be getting a good representation of the actual tumor if you only do a core biopsy. So just to illustrate that the diagnosis in our patients was made through adenopathy, the majority site being cervical, but also it was diagnosed on a colonic biopsy, it was diagnosed on an extradural spinal mass, as well as a buccal biopsy. So the final conclusions from Evans et al., and Barra concurs with their findings, was that non-mediastinal gray zone lymphoma was highly prevalent. Non-mediastinal gray zone lymphoma patients were older. They more often had bone marrow involvement at presentation, and we agree. And also they had more extranodal disease. Moving on to a little on the diagnostics of gray zone lymphoma, I want to start off, this is a table illustrating the difference between primary mediastinal in terms of morphology versus classical Hodgkin versus gray zone lymphoma. As you will appreciate in the first column, primary mediastinal has more of a diffuse growth pattern with atypical larger cells with clear cytoplasm, with a little to no inflammatory background, as compared to classical Hodgkin lymphoma, where you have more of a nodular type of growth pattern with bands of fibrosis, Reed-Sternberg type of cells, and inflammatory background. The thing with gray zone lymphoma is they have transitional features, so it can be in between. And there's also, it's important to note there's varying degrees of discordance between what you see on morphology and what you find on immunophenotypic analysis. So the tumor architecture is variable. It may be diffuse, as in keeping with primary mediastinal, or it may be nodular in keeping with Hodgkin lymphoma. It may have a centroblastic or immunoblastic appearance in keeping with primary mediastinal, or you may have the Reed-Sternberg-like cells, as is Hodgkin. In terms of EBV positivity, the interpretation is controversial, but occasionally EBV may be present, but it is said that you better classify these cases as diffuse large B cell with EBV positivity. In terms of genetic and molecular markers, as in primary mediastinal and classical Hodgkin, there's alterations in the JAK2 at 9p24 and the CETA locus, as well as the REL locus at 2p16. Comparing the immunophenotype between these 3 entities, in primary mediastinal, you'd expect a mature B cell phenotype with expression of CD20 and CD79A, with absent and weak CD15. In classical Hodgkin, you may expect a negative or weak B cell marker expression, with the Reed-Sternberg cells expressing CD30 and CD15. And in gray zone lymphoma, as mentioned, you have this discordant immunophenotype. And what I mean by that is you may have cells that look centroblastic, but they may not express the B cell markers as expected, but they may be positive for CD15 and CD30. And in contrast, the Reed-Sternberg cells, where you expect CD15 and 30 to be positive, you may see an expression of the B cell markers CD20 and CD79A. This is just a diagram indicating the discordant immunophenotype, and I think it explains it quite well, where in a Hodgkin lymphoma like of picture, you will expect CD15 and 30 to be positive, but as you can see, it's quite weak, and CD20 is by comparison quite strong. And on the primary mediastinal B cell, where you expect CD20 to be positive, it's quite weak, and the CD15 and 30 rather. So it's really a mixed bag, and this discordance really creates a lot of confusion and makes the interpretation and the diagnosis quite difficult and quite challenging. In terms of the immunophenotype on Evans et al. Study, it is recommended that the minimal panel to diagnose gray zone includes your B cell markers, CD20, CD79A, and PAX5-MUM1, and some of the markers for Hodgkin, CD30, 15, your background T cell CD3, and your EBV. It was interesting to note that in their study, the CD20 was positive in 93% of the cases, and they routinely do 79A. CD30 and CD15 was also positive. And interestingly, in 28% of the cases, it was EBV positive. By comparison, in our study, all of our cases were CD20 positive, and we had a higher rate of CD30 and CD15 being positive. We don't routinely do 79A, and therefore it was difficult to interpret. The MUM1 was also difficult to interpret because it was only done in 6 samples, and EBV as well. So we don't want to pass any judgment or any conclusions from this cohort. Moving on to management, just a point to note is there are no standard management guidelines for gray zone lymphoma, either in the upfront setting or in the relapse refractory setting. And the reason for this is the great amount of variability. The case series are very small, and there's isolated case reports. In Evans et al. With the 112 patients, the most common way of the therapeutic approach upfront was either CHOP plus minus rituximab in the majority of cases, 51%, or ABVD plus minus rituximab in 30%. Other regimens that they chose was dose-adjusted EPOC plus minus rituximab, or other regimens, for example, CVED, etc. 2/3 of their patients received rituximab as part of their frontline therapy. In terms of the Paraguanath cohort, our upfront regimen choice was CHOP in 41% of the cases, and interestingly, we did not use concomitant radiation, and perhaps this is something to consider going forward. ABVD was used in 23% of the cases, and other regimens were R-CHOP, BCVBP for those that had a poor EF, and other regimens like CHUP and CVP. In terms of the outcome of Evans et al., this was a Kaplan-Meier curve for 2-year progression-free survival, and it showed that patients that received frontline therapy with a diffuse large B-cell containing regimen, so either R-CHOP or dose-adjusted EPOC plus rituximab versus ABVD with rituximab, and it showed a significantly inferior outcome with ABVD as compared to diffuse large B-cell. So this a diffuse large B-cell regimen. So this slide clearly illustrates the superiority of R-CHOP or dose-adjusted EPOC plus rituximab as compared to a frontline regimen of a Hodgkin-containing regimen. This is also a Kaplan-Meier curve for those patients that received rituximab as part of frontline versus those that did not. And as you will appreciate, the 2-year progression-free survival was 51% for those that received rituximab versus those that did not. So again, clearly a significant benefit of adding rituximab upfront. The current recommendations is therefore to use R-CHOP or dose-adjusted EPOC with rituximab as frontline treatment for gray zone lymphoma. And there's advocacy for the use of consolidative radiotherapy after chemoimmunotherapy for those patients that have localized or bulky disease more than 10 centimeters in size. For patients with relapse in refractory gray zone lymphoma, as we will come to just now, salvage chemotherapy followed by autologous stem cell transplant should be considered, and targeted therapeutic agents seem to be the way of the future. Current words of wisdom so far in our talk: gray zone lymphoma is quite challenging. You might sprout a few gray hairs as we did with the stalk. Your pathologist is your friend when it comes to making a diagnosis of gray zone lymphoma. Non-mediastinal gray zone lymphoma is a thing, and you should not only consider gray zone lymphoma in the context of mediastinal disease. An excision biopsy is preferable for the diagnosis, and management strategies are quite variable, but upfront, a diffuse large B-cell containing regimen seems to be preferable. Stay tuned for more. Garrick?
Thank you, Ramana. So as you can see, again, it's an entity that has seemingly has us caught between two worlds. So just looking at the case of relapsed refractory disease. So again, this was some of the outcome of some of our patients at Chris Hani Baragwanath Hospital. Just to look at, again, the 7 cases who have demised. So 2 were from neutropenic sepsis, others were from, 1 from renal failure and tumor lysis syndrome. 1 was suspected PE and the other one was progression of disease. And just to note that all of the patients who had demised, that the median age again is a bit older, so 47, and all had non-mediastinal disease of those patients who had demised. So again, relapsed refractory disease, that chemotherapy is only effective in half of these cases as well. Generally, the relapse occurs quite early on in the disease. So the median time to progression is generally 8 months from diagnosis. And majority of the cases of gray zone lymphoma will actually relapse while they're on therapy or within 12 months of completion of the initial therapy. And generally at the time of relapse, that it involves sites that are beyond the mediastinum. And those extranodal sites will include the liver, pancreas, kidney, as well as the central nervous system. This was just a nice diagram from an Asian study from 2021, where it basically looks at the treatment approach for primary mediastinal B-cell lymphoma. So again, upfront, as Romano has mentioned earlier, the rituximab-containing regimen with either CHOP or an infusional regimen with EPOC. Again, using FDG PET as interim staging. And then again, looking at those, so radiation therapy, specifically for those with mediastinal masses, and looking at other therapeutic regimens in patients with non or disseminated disease or systemic disease. Again, reusing rituximab-based therapy with reinduction chemotherapy, and then eventually moving to stem cell transplantation with or without radiation therapy, and novel markers like PD-1 blockade, as well as brentuximab. Just looking at treatment approaches. So again, they recommended that high-dose chemotherapy or salvage regimens should be adopted, similar to those ones that are used in diffuse large B-cell lymphomas. So that would be your rituximab with ICE or rituximab with DHAP. Again, after salvage therapy, when it is achievable, so sometimes it's not always achievable in these patients because they relapse quite early on, but stem cell transplantation seems to be of benefit in those patients who have deemed themselves to be chemosensitive or responsive. Generally, autologous hematopoietic stem cell transplant is not offered to patients, particularly in those patients who do not have chemosensitive disease. In a retrospective study of 99 patients in Europe with the Lymphoma Study Association in 2016, about 28% of their patients presented with primary refractory disease. So that was progression that was under first-line treatment or relapse within 1 year. So patients treated with a standard regimen that was either more catered towards diffuse large B-cell lymphoma or more Hodgkin type treatment, they had a worse event-free survival, and their overall survival was also worse than those patients who were treated with more dose-intensive chemotherapy. Again, they've noted that rituximab that was added to chemotherapy wasn't associated in relapse disease with a better event-free survival or overall survival. And they didn't look at the use of brentuximab vedotin in the study, but did comment that this may be an important drug to consider in relapse refractory disease. So just to look at what is brentuximab vedotin. So as you can see on the diagram on the left, that it's a CD30 directed antibody drug conjugate, which is composed of 2 elements. So it's usually the chimeric IgG1 antibody, which is usually derived from mouse or murine derived, and that's specific for human CD30. And then attached to the IgG1 antibody is your microtubule disrupting drug, which is monomethyl auristatin E, which, as its name states, it disrupts microtubules within the tumor cells. Just to look at it a bit more in terms of the diagram on the left. So again, malignancies that express CD30, this IgG1 antibody will then dock onto the CD30 receptor, and then via a clathrin-mediated mechanism. So you can see in the diagram here that there are clathrin pits, and these will then internalize. And again, the vesicle that is internalized fuses with lysosomes where your monomethyl auristatin is released. Again, in the cell, it inhibits microtubule assembly, but then also to note that small amounts of these, of the monomethyl auristatin E can diffuse into the tumor microenvironment, where it also exerts potent cytotoxic effects on the cells, particularly in Hodgkin and these Reinsterdberg cells. Again, what comes into question here is the efficacy of brentuximab vedotin in patients expressing high levels of CD30. But what's not mentioned in literature is what this threshold of CD30 expression is with patients who may benefit from brentuximab vedotin. Again, it displays, BV displays efficacy in patients who express high levels of CD30. What's not clear, as I've just mentioned, is what is this level of expression that would have greater efficacy in patients. So primary mediastinal B-cell lymphoma is also characterized by elevated expression of CD30, but there is a caveat to this. So in other studies, so single arm phase 2 trials that have been conducted in patients with relapsed refractory lymphoma, they looked at the midterm evaluation of its use in relapsed refractory primary mediastinal and showed that the overall risk reduction was actually unexpectedly lower, and thus the study was terminated prematurely. But there have been multi-center research studies which have looked particularly at the synergistic activity or action of BV when it's combined with nivolumab, which is an anti-PD-1 checkpoint inhibitor. So alone, it may not exert the greatest effect, and depending on the CD30 expression, but when combined with PD-1 or anti-PD-1 checkpoint inhibitors, it may exert a greater effect. So just look at what are some of the other uses of brentuximab vedotin in hematology and oncology. So again, it's classic Hodgkin lymphoma, those previously untreated, consolidation, even post autologous stem cell transplantation, it can be used as consolidation, relapsed classical Hodgkin lymphoma. Again, your other CD30 expressing tumors, systemic anaplastic large cell lymphoma, primary cutaneous anaplastic large cell lymphoma, CD30 expressing peripheral T cell lymphomas, as well as other orphan indications for more rarer entities, so those that are listed below. Just to look at your program death ligand, so PD-1 and PD-2 inhibition, just to know that tumor cells express PD-1 ligand or PD-L1, which is seen in the diagram on the left, and the PD-1 is expressed on T cells. So this docking of the PD-1 ligand and the docking onto the PD-1 receptor basically activates a signaling pathway which inhibits this immune response. So inhibits T cell mediated destruction of tumor cells. So what's particularly in terms of, if we look at pembrolizumab or as a marker, it basically blocks this interaction between PD-1 ligand and PD-1 on T cells. And that allows the immune system to recognize and attack tumor cells appropriately. So again, primary mediastinal B is associated with 9p24 genetic abnormalities and an overexpression of PD-1 ligand, and thus makes them more susceptible to this blockade. So again, PD-1 ligand inhibitors are effective in the treatment of multiplicity of tumors, so melanoma, lung carcinomas, as well as breast carcinoma and metastatic renal cell carcinoma. So again, there's a role of pembrolizumab in the treatment of relapsed refractory primary mediastinal B-cell lymphoma. Again, in the study that was the keynote study, it showed that it had or exhibited a high response rate, longer lasting activity, and manageable safety in these patients as well. And again, they've recommended that it should be regarded as first-line treatment in refractory disease, particularly in primary mediastinal B-cell lymphoma or gray zone lymphoma. To look at other novel molecules that may be effective in the pathobiology of primary mediastinal B-cell lymphoma, so we'd have to look at certain signaling pathways, so the NF-kappa beta signaling pathway, as well as the JAK-STAT signaling pathway and its secondary messenger profile as well. So that's indicated in this diagram, which is quite complex, but just to look at the two different pathways as seen here. So again, the pathobiology of the disease or primary mediastinal B-cell lymphoma relies on multiple pathways. So the REL pathway, JAK-STAT, PD ligand 1, PD ligand 2, and nuclear factor kappa beta. And through comprehensive genomic analysis of numerous samples in gray zone lymphoma, they've found that there are certain oncogenic mutations in genes that encode these pathways. And this, as Romano has also mentioned previously, some of these genes, and this was associated with immune evasion. So for this reason, there's been repurposing of JAK2 inhibitors such as ruxolitinib and other JAK2 or FLT3 inhibitors, which have shown or demonstrated and have found to be evaluated in Hodgkin lymphoma and primary mediastinal B-cell lymphoma. However, due to the small numbers of these cases evaluated, their complete efficacy has not been entirely determined. So again, CAR T cells. So generally, just to, overview what CAR T cells are, is that's T cells are harvested or taken from a patient's blood, and then they basically edited it in the lab. And so the lab will add a gene for a receptor, so called the chimeric antigen receptor, or CAR. And this basically allows these T cells to attach to a specific cancer cell antigen upon reinfusion. So again, the Zuma trial showed that CAR T cells were important treatment regimen in relapsed refractory diffuse large B-cell lymphoma. And there's also been National Cancer Institute trials of autologous anti-CD9 chimeric receptor T cells in patients with primary mediastinal B-cell lymphoma. But again, the efficacy, or the bottom line here, is that there have not been adequate studies that have adequately confirmed the use of this as a novel therapeutic strategy for the effective treatment of relapsed refractory primary mediastinal B. So more information is needed on this. Again, looking at bispecific antibodies. So these again are engineered antibodies which have two binding sites. So the one binds to CD3 positive T cells. So it binds those CD3 positive T cells, to CD19 positive B cells. And then the other part of the receptor is directed against a co-stimulator on T cells. And so it brings these CD3 T cells and the tumor cell into close proximity and results in their associated destruction. So the effective, or the efficacy of blinatumomab, which is a bispecific CD19 directed bispecific antibody in patients with relapsed refractory non-Hodgkin lymphoma, has also been confirmed. But again, they've looked at new bispecific IgG1 antibodies, so epcoritamab, which basically can direct T cells more specifically to CD20 positive tumor cells. And this has shown to be an important modality in relapsed refractory B-cell non-Hodgkin lymphoma. Again, studies investigating these bispecific monoclonals in relapsed refractory primary mediastinal B-cell lymphoma has not yet been studied, but has been commented on in literature as being a novel strategy for relapsed refractory primary mediastinal B-cell lymphoma and its treatment. So looking at specific, looking at prognostic markers or prognostic indices in the entity of primary mediastinal B-cell lymphoma or gray zone lymphoma. So the IPI and its derivatives, they've been established for diffuse large B or classic Hodgkin lymphoma. And the optimum scoring system for gray zone lymphoma still remains unelucidated. But in a cohort of 61 patients from a study that's listed below, also from Asia, shows that the NCCN IPI is preferential for use in clinical practice in patients with gray zone lymphoma. Again, initial studies in the study listed below have shown a more favorable course in tumors that have a lower metabolic activity, a decreased total lesion glycolysis, and that's measured by FDG PET uptake. Multivariate analysis have also identified performance status as the most dominant prognostic factor for progression-free survival. And again, as you would expect, that advanced disease is also a significant prognostic factor in relapsed refractory primary mediastinal B-cell lymphoma or gray zone lymphoma. Again, CD20 positivity in malignant cells also independently predicted progression-free survival on analysis, on statistical analysis. And again, I think that gene expression profiles of a number of these malignancies will help clearly delineate them into, the systemic aspect of them in diffuse large B-cell, non-otherwise specified, or into primary mediastinal B-cell lymphoma. So some discussion points. So is gray zone lymphoma more related to classic Hodgkin lymphoma or diffuse large B-cell lymphoma? Again, it's this entity that straddles two different types of entities. So some molecular findings have shown that gray zone mediastinal is more related to classic Hodgkin lymphoma than primary mediastinal B. However, as we've mentioned previously, that sometimes the immunohistochemistry doesn't always match the entity, and also sometimes the gene expression profiles of characteristic genes in Hodgkin lymphoma and primary mediastinal B-cell lymphoma indicated that primary mediastinal B-cell lymphoma is actually 1/3 identical to nodular sclerosis Hodgkin lymphoma. So in this case, will adding brentuximab vedotin as a molecule, as a treatment modality, be of value to cases with more of a diffuse large B-cell lymphoma profile and a lower expression of CD30? And similarly, will use of so-called or B-cell directed therapy against CD19 and CD20 be of value in cases where expression of the profile is more related to classic Hodgkin lymphoma. So some final topics to ponder. So again, the gray zone lymphoma poses a significant diagnostic challenge for both the clinician as well as the hematopathologist and pathologist. Again, to take note of the new WHO 5th edition definition. And again, I think that more gene expression profiling will help us delineate more clearly those entities of mediastinal gray zone lymphoma or those that have more of a systemic presentation and should otherwise be referred to as diffuse large B-cell lymphoma, not otherwise specified. That there's no standard management guidelines for the upfront or treatment or for the relapse refractory setting. But I think more of a diffuse large B-cell like treatment using rituximab in the upfront setting may be of value. Again, in the relapse refractory setting, is that more of a salvage regimen is more useful. And not to negate the fact that radiation therapy may be of value, as well as stem cell transplantation. Targeted therapeutic agents are the way of the future. So once we can more or clearly delineate the genomic profile of these malignancies, we'll be able to use these targeted therapeutic agents, as well as when these agents are available to us. So we need more local research data from registries from across the country to draw more definitive conclusions. So that is our presentation. Thank you for your time. Let's just see if there's any questions.
Thank you very much, Garrick and Romana, for an excellent presentation. It's really comprehensive. I think there are a few comments from Jacques.
Yeah, I'm just going back to that slide, Dr. Philip. I think Dr. Malherbe just asked about sequential synchronous and metachronous lymphoma. As far as I understand, the concept of gray zone lymphoma is where you have this hybrid disease entity where you can have in one tumor, features suggestive of diffuse large B-cell and classical Hodgkin. And they differentiate this from composite lymphoma where you have two distinct neoplasms occurring at the same location at the same time. So that would be synchronous rather than this hybrid type of gray zone picture. So it's two distinct type of lymphomas at the same location at the same time. And sequential type of lymphoma where you can have Hodgkin first followed by diffuse large B-cell or vice versa. Generally, Hodgkin occurs first followed by diffuse large B-cell, and that's referred to as metachronous lymphoma. So as far as my understanding goes, they differentiate these three entities: gray zone lymphoma, composite lymphoma, and sequential lymphoma. But it's open to discussion from the floor.
Thanks. Can you hear me? It's Jacques here. We placed the comment. So I mean, I take that, and I'm just sort of looking at the WHO a sentence at the end of the in the gray zone lymphoma section where it says, in instances of composite or metachronous lymphomas, the various composite exhibits a phenotype characteristics of that entity. So the way the sentence is written almost tells me that you can get a gray zone lymphoma that has either a composite or a metachronous lymphoma. So I'm just, I think I just want to highlight that it's not quite clear in the WHO. I mean, if I read the WHO, it seems like that is possible, but I assume that you got this from the other literature that you were checking on this. So yeah, that's why I asked the question, because it seemed a little bit counter to what if I read the WHO. But I mean, again, these are rare entities, so it's possible that there is some differences in opinion on how you classify these things.
Yes, and I think the new WHO definition, the 5th edition, where it separates mediastinal gray zone versus the non-mediastinal presentation as diffuse large B-cell, not otherwise specified. Maybe that would be better. It may provide more of a clearer type of definition going forward.
Okay, no, that's interesting. And then just just to comment on my initial thing is there was I came across just incidentally on a really interesting hematological publication from last year, where they looked at B cell lymphomas that express CD30, and there were, I can't remember now the percentage, but there was a significant percentage which were gray zone lymphomas, and where they basically gave BVR chip, essentially R-CHOP with the vincristine removed and replaced with brentuximab, because there's a increased incidence of peripheral neuropathy with vincristine and brentuximab. So, and it actually just showed very good responses, 100% overall response with 80% complete responses, and in a 2-year progression-free survival of 85%. And a 2-year overall survival of 100% in that sort of phase 2 trial. So just, yeah, I think it makes sense to me in these lymphomas that express both CD20 and CD30 to use the combination of Ritux and brentuximab upfront. Obviously, this is not really feasible for us, but just to know that it's being used, and that may be a good option if available in the frontline setting.
Yes, thanks, Dr. Hope. I agree with that as well. I think just access again that remains, and I think the other area that was a bit of unclear for me was I don't know if there was a certain threshold of CD30 expression that for which those patients with brentuximab may not be as useful, but I agree that in the upfront setting that it's an agent that we should.
Yeah, I don't know in that trial, but I know that, and if anybody else has some more information can comment, but I know that in the T cell setting, there was that trial that looked at also brentuximab in the frontline setting. Basically, I think it was BV CHOP or BV chip or BV chip. I can't remember exactly, but that the cutoff they used in the T cell setting was 10% positivity. So that's actually quite a low CD30 positivity, and I'm not sure if that one can extrapolate that to the B cell setting. But yeah, in the T cell, this is non-peripheral B cell lymphoma, not otherwise specified, that is expressing CD30, and the cutoff they used in that trial was 10%.
Thank you.
Thank you very much, Chuck. How many patients with gray zone lymphoma do you see?
Not many. I must say, I previously didn't really give this entity a lot of consideration. I mean, you seem to actually accumulated quite a large series, which I thought was really impressive. And I made a comment to Caroline now that I must commend you guys for just generally keeping good records and good registries of your patients. It's really impressive. But we probably, I know of about 2 or 3 patients, and so we've either missed them or we just see few. We're obviously a much smaller center. We had and this is also where I asked this question about the composite or the synchronous or whatever you call them lymphomas. We had a young boy who presented with a paraplegia, and on spinal mass biopsy, it was a diffuse large B-cell lymphoma, and then we did his staging, and on his bone marrow, he had a Hodgkin's lymphoma. And at that stage, I didn't really, this was about 2 years ago or a year and a half ago, and at that stage, I didn't really consider the entity of gray zone lymphoma. It wasn't on my radar, and we decided to treat the patient. We actually gave him DHAP intercalated with high-dose methotrexate, and ended up transplanting him with an auto up front. He's done incredibly well. So, I mean, it's a bit of a typical approach, but yeah. So I've not seen many.
Yeah, we had a patient with a synchronous lymphoma where I think the biopsy of the nodes above the diaphragm came out as diffuse large B cell, and below the diaphragm, and we did it on the same day, or Hodgkin lymphoma. So, but that one wasn't a gray zone lymphoma. It's a challenge to treat. But yes, and anybody else with any comments? Other centers, do you have any experience with gray zone Because I know we are battling with the management of these patients. They don't seem to do well with either of them. I agree with Romana, we should try and add rituximab. It has not been an approved indication for us yet at our center, but we should be able to get patients onto it because there's so few patients.
Yeah, I would just sort of argue with the guys who sort of give the approval or not for the rituximab is not really going to know the difference between a diffuse large B and a gray zone lymphoma. So I would tend to just say that you've got a large B cell lymphoma expressing CD20, and hopefully they will take that as yeah. So I don't
Yeah, I
mean
know.
that,
We have ways of getting around things. Or we can try, but it's very interesting presentation. And yes, I know we've had 20 cases. I didn't realize we had reached that many, but they are really challenging for us. And we had 6 last year, which means the numbers are growing, or our pathologists are finding them more frequently. They're getting the experience now. And
Yeah, I think what we also found, Dr. Philip, in collecting this data was that, initially a lot of the cases were diagnosed as Hodgkin, and then on supplementary review or after discussion, at a combined meeting, that the consensus was that it was actually gray zone lymphoma. So perhaps these multidisciplinary meetings or these review sessions are quite essential, and perhaps we are missing a large proportion of gray zone lymphomas.
that is very possible. Yeah, we need to look into it and possibly do an MED on it and publish our findings. Any other questions from anybody? I don't have much to say, but it's an entity that we are still getting, what shall I say, our thoughts about and how we should best manage these patients. If they look more like Hodgkin, we were managing them as Hodgkin. Otherwise, we were managing them as non-Hodgkin lymphomas. If they didn't respond to one therapy, we changed to the other. We've only had access to BV in the last year. We were restricted to 7 patients, so we don't have many options with regards to BV. But it'd be nice. I'd like to get some more BV, if possible, from our PTC and try and use these on these patients and see where the response in our patients are different to that of the literature.
And it would also be interesting to see if we could try and get it as upfront, therapy as well, Dr. Philip. But I guess that maybe is a bit too much to ask.
At this moment, I think it's a bit too much to ask, but we can try. There's no harm in trying. Anybody else with any experience or any comments to make? I know we are early, but I don't think we need to take all the time if there's nothing much to say.
Hi, Dr. Philip.
Hi, please speak.
It's Moses here. Yeah, very nice presentation. I got an interesting article in the Oncologist, I think published sometime, I think on the 10th of August, just to address the question that Garrick was talking about, the level of expression of CD30. It didn't find any difference in the response rate to brentuximab vedotin, whether the CD30 expression was above 10% or less than 10%.
Thank you, Moses. Thank you.
Thank you. So what you're saying is the response was good in spite of whatever the level of expression, or the response was not good?
So the expectation was that maybe with higher CD30 expression, there would be better response to brentuximab vedotin, and that wasn't the case from that study. I'll try to send the article on the group.
Thank you,
Thank
Moses.
you. It's very much appreciated. Thank you very much. Any more comments? Otherwise, it leaves me to thank both Romana and Garrick for such excellent presentations and challenging us to think outside the box. And I believe next week's presentations are on plasmablastic lymphomas, which is something we look forward to as well. Thank you, everybody, for coming, and we can have an early day today. Goodbye.
Thank you, Philip.
Thanks.
Thanks, Prof. Berg. Thanks, Dr. Philip.